Here we'll learn about the pathophysiology of diabetes mellitus, which is a metabolic disorder that affects up to 10 million people worldwide. In this tutorial, we'll focus on the differences and similarities of type 1 and type 2 diabetes. For an in-depth look at the biochemistry and physiology of diabetes mellitus, please see the tutorial titled simply Diabetes mellitus. To begin, start a table and denote that diabetes refers to a collection of metabolic disorders in which a lack of insulin secretion and/or insulin action leads to hyperglycemia. Chronic hyperglycemia produces dysfunction and damage of multiple organs, including the heart, kidneys, eyes, and peripheral nervous system. In this tutorial, we'll focus on the subtypes, types 1 and 2. Denote that other subtypes include monogenic diabetes, which includes maturity onset diabetes of the young, secondary diabetes, which includes diabetes caused by infections, drugs, and other disorders that produce hyperglycemia, and gestational diabetes. You can learn more about these subtypes via the links in our notes. We can use a few different measurements for diagnosing diabetes mellitus. To note that the diagnostic cutoffs are a random plasma glucose level of 200 plus milligrams per deciliter, or a fasting plasma glucose level of 126 plus milligrams per deciliter. Prediabetes is defined as a condition where glucose levels are elevated but not high enough to be classified as diabetes. Pre-diabetic patients are at high risk for type 2 diabetes and the ensuing cardiovascular complications, and thus are advised to take steps to prevent these developments, such as increasing physical activity and losing weight. The CDC reports that 1 in 3 Americans is pre-diabetic. Before we dive into types 1 and 2, let's do a quick review of insulin. For a more complete review, please see the links in our notes. First, indicate that elevated glucose levels, such as occur following a meal, triggers pancreatic beta cell release of insulin. Show that incretins GIP and GLP-1, which are secreted from the gastrointestinal tract after food intake, increase the rate of insulin secretion. This is known as the incretin effect. And as we'll see, some patients with type 2 diabetes benefit from drugs that increase incretin actions. Then show that insulin increases glucose uptake in both striated muscle, skeletal and cardiac muscle, and in adipose tissue, and promotes fuel storage in these tissues. Recall that glucose uptake by the liver is not insulin dependent, but insulin has various metabolic actions there too. Now let's learn about type 1 diabetes, which accounts for 5 to 10% of all diabetes mellitus cases. First, indicate that type 1 diabetes is caused by autoimmune destruction of pancreatic beta cells. Insulitis is often visible in pancreatic tissue samples. We show that T cells with failed self-tolerance for islet antigens mediate this destruction. For a review of T cells and self-tolerance, see the links in our notes. During this process, islet autoantibodies are produced and circulate in the blood, indicate that these serve as a helpful marker of type 1 diabetes and include autoantibodies that target insulin, GAD65, ZNT8, which is zinc transporter 8, and IA2, which is islet antigen 2. Note that these autoantibodies are not believed to be the source of beta cell damage, but just markers of it. The etiology of type 1 diabetes includes both genetic and environmental factors. One of the best studied genetic associations is with variations in HLA alleles. Recall that HLA molecules are cell surface proteins that present peptide antigens to T cells. Variations in the genes coding for class 2 DR and DQ cell surface proteins have the strongest risk association with type 1 diabetes. It's thought that environmental triggers intersect with genetic factors, though the specific environmental triggers are uncertain. Viral infections are thought to play a role in development of type 1 diabetes, particularly enterovirus infections, but study results have been conflicting and causative links are uncertain. Likewise, diet during infancy and childhood are thought to play a role, and it's been proposed that breastfeeding has independent protective effects against type 1 diabetes. However, recent studies seem to disprove this long-held notion. Indicate that the onset of type 1 diabetes is often during childhood, but not exclusively. It's Likely that some adults who have been diagnosed with type 2 diabetes based on their age have been misclassified, which can have deleterious effects on their treatment. Thus, to avoid perpetuating misdiagnosis, we no longer refer to this disorder as juvenile diabetes. Because type 1 diabetes is due to autoimmune destruction of insulin-secreting cells, we see a progressive reduction in insulin levels over time as more cells are destroyed. See the link in our notes for a graph displaying the typical three-phase model of type 1 diabetes progression. However, be aware that hyperglycemia may be transient in some cases with variable insulin needs, particularly in adults diagnosed with type 1 diabetes. Lastly, indicate that type 1 patients who have absolute insulin deficiency require exogenous insulin administration. Be aware that there's another form of type 1 diabetes called idiopathic type 1 diabetes in which the autoimmune response is not involved. This type is very rare. Next, let's learn about type 2 diabetes, which accounts for the majority, 90 to 95% of all diabetes. Indicate that type 2 diabetes is characterized by peripheral tissue insulin resistance and relative insulin deficiency due to mild beta cell destruction caused by amyloid deposits. Be aware that these amyloid deposits, which are visible in histological samples, were originally called hyaline. Amyloid polypeptides are co-secreted with insulin in the pancreas and can build up to form the characteristic deposits associated with type 2 diabetes. Next, indicate that the etiology of type 2 diabetes is complex and is associated with obesity and central fat distribution, sedentarism, inactive lifestyle, stress, and inflammation. The insulin resistance of peripheral tissues is due to the loss of GLUT4 receptors. Fortunately, exercise is known to increase the number of these receptors in skeletal muscle, which is why exercise is commonly recommended for patients with insulin resistance. Type 2 diabetes also has strong genetic associations, which are polygenic with complex inheritance patterns. Indicate that this is a historically adult-onset disease, but is increasingly common in children due to higher rates of childhood obesity and inactivity. Thus, we no longer refer to it as adult-onset diabetes. Write that patients may initially have elevated insulin levels in response to insulin resistance in the peripheral tissues, but because the pancreatic cells can't keep up and/or are undergoing destruction by amyloid deposits, insulin levels will fall. And because of the relatively slower onset of the disease, many patients are asymptomatic with diagnosis only occurring after a routine blood test. This is why we test patients who meet the risk factors outlined above for prediabetes and diabetes. Treatment of type 2 diabetes is complex and needs to be tailored to the individual and achievable glycemic targets. The first step may be recommending diet and exercise, and perhaps administration of metformin, which decreases hepatic glucose production. If hyperglycemia persists, patients may be prescribed insulin, GLP-1 receptor agonists, recall the incretins from the beginning of this tutorial, or SGLT2 inhibitors, sodium glucose transporter 2, which allow the kidneys to get rid of excess glucose via the urine. The goal of type 2 diabetes treatment is to reach glycemic targets to avoid the organ damage caused by hyperglycemia. However, these drugs can be costly and/or have contraindications that must be considered for each patient. Now let's learn about the signs and symptoms of hyperglycemia. Indicate that we'll learn about the 3 P's: polyuria, polydipsia, and polyphagia. First, show that hyperglycemia surpasses the renal glucose reabsorption threshold, which results in glycosuria, glucose in the urine. Glycosuria induces osmotic diuresis, which results in polyuria, frequent urination. As you can imagine, polyuria leads to depleted water in electrolyte stores, which causes polydipsia, increased liquid intake. And because insulin deficiency produces a chronic catabolic state, patients are often hungry, leading to polyphagia, increased food intake. Recall that despite the increased food intake, type 1 diabetes patients typically have muscle weakness and weight loss due to the inability to store and use glucose as a building block for muscle or fat. Finally, let's consider some serious complications of diabetes. First, indicate that patients with undertreated type 1 diabetes can experience diabetic ketoacidosis, which is characterized by nausea and vomiting, fatigue, a fruity odor, and Kussmaul breathing, a rapid, deep breathing pattern. These features reflect the acidic state of the body, which can ultimately lead to coma. Fluids, electrolytes, and insulin are given to normalize the blood glucose. Patients with type 2 diabetes are more prone to hyperosmolar hyperglycemia syndrome, HHS, which occurs when a patient with polyuria is also deficient in water intake, thus leading to severe dehydration, which can be fatal. Insufficient water intake can occur in patients who are unable to drink their own, such as after a stroke or other debilitating conditions that limit hydration. Be aware that hyperosmolar hyperglycemic syndrome has a mortality rate of up to 20%, much higher than the mortality rate for diabetic ketoacidosis. Patients require saline, insulin, and electrolytes. Next, indicate that patients with either type of diabetes are at higher risk for vascular disease due to chronic hyperglycemia. Show that micro and macrovascular dysfunction can lead to heart failure and atherosclerosis, which can produce myocardial infarction or stroke, kidney damage, visual impairment, and peripheral nerve dysfunction. Furthermore, children are at risk for impaired growth, and all patients are more susceptible to infection due to immune suppression. Lastly, indicate that patients with diabetes are ironically susceptible to hypoglycemia due to missing a meal, excessive physical exertion, or excessive insulin administration. Watch for dizziness, sweating, palpitations, and tachycardia, and treat with glucose to correct the blood sugar levels. In the acute emergent setting, hypoglycemia is far more dangerous than hyperglycemia. Sustained levels of hypoglycemia can lead to severe brain damage that may be irreversible in short periods of time. Therefore, in any diabetic patient, always rule out hypoglycemia before thinking about hyperglycemia. For more information regarding the complications of hyperglycemia, including retinopathy, peripheral neuropathy, and nephropathy, please see the links in our notes. This concludes our diagram.